Hello, I'm Dr. Jack West, Associate Clinical Professor and the Executive Director of Employer Services at the City of Hope Comprehensive Cancer Center in Duarte, California. Welcome to Medscape Oncology Insights. Joining me today is Eddie Guerin, Associate Professor of Medicine at UCLA in Los Angeles, California, and Dr. Mark Lewis, Director of Gastrointestinal Oncology at Intermountain Healthcare in Utah. Thanks so much for being here, guys.
Thanks for having us, Jack.
Thank you.
We're going to talk about just general impressions of the state of oncology and some of the challenges we're facing. And I would say that right now, one of the things that I'm struck by in general practice and at this meeting is what I fear is a growing disparity between the availability of resources and the knowledge base at more specialized centers, and as people get further out into the community setting, just not having the same opportunities, the same subspecialization, and it translating into real challenges in terms of delivering what we would consider the best care to patients. And I think it's a real frustrating issue. Specifically, I find myself thinking back to when I was in college and happened to be taking a couple of different humanities classes at a time after my pre-med requirements, and they would assign some ridiculous amount of outside reading, 400 pages or so a week, and it was so much that I would just give up and say, you can't do this, this is not attainable, and it's not fair for professors to expect that that's the only thing you're going to be doing. My concern is that we are getting a bit like that when the people who are talking about what everyone should be doing are more narrowly specialized and say we should be doing repeat biopsies and get 12 different kinds of molecular marker studies and know what to do. I don't know a clear answer to this, but do you have any sense that it's getting or become unwieldy, unmanageable for the docs who are seeing 12 or 15 kinds of cancer a day? Because it's hard for many of us to keep up with all the developments just in one or two, let alone 10 or more.
Totally agree. You and I are kindred spirits. If we had known each other back in college, I was a double major in classics and biology. I did the biology just in case the classics didn't pan out. And I was trying to be like my father, who was a scholar and knew multiple languages. And so one semester, I overburdened myself by trying to take Greek and Hebrew at the same time. And the reason I bring that up now is those were two different languages. I immediately found myself out of my depth. I was getting them confused. My Alephs and my alphas were getting mixed up. And I sort of feel like that now. I feel like oncology, and it's a wonderful problem to have, we have so much discussion in these increasingly different areas, but it's almost a Tower of Babel where I feel like breast cancer is now a different language, if you will, than, say, lung cancer. And it's incredibly difficult to be a polyglot and master all of these different disciplines.
I mean, that's really my concern, that we're getting siloed and we're speaking different dialects, and it becomes increasingly difficult for a general oncologist to keep up with what is not even feasible. We haven't yet translated the Cliff Notes version of what you need to know. Right. I don't know, Eddie, have you thought about this? Because what I'm just seeing in the actual data in practice as we look at real world evidence is that it's not getting executed the way that we'd hope to. And we can roll our eyes and say, oh, why can't they keep up? But I don't think that's necessarily realistic when it's just at a torrid pace.
No, and for me personally, I see only thoracic oncology outside of the time when I do inpatient service. And I wonder how people will be able to deal with all of the information. One of the things that then becomes sort of frustrating is that there has to be sort of an explanation to people. And so next generation sequencing is probably the best example. You can't expect everyone to be familiar with all of these things across all of the histologies. So the reports come back and they simplify and in the end really have a lot of power over what patients actually receive, right or wrong. They'll come back and they do interpret for the patients, and sometimes the interpretations make sense. But of course, as we all know as medical oncologists, oftentimes context is important, and that obviously is not going to come in those reports, and it can't come in those reports.
Yeah, I'm actually really concerned that I think NGS is, of course, a new world of molecular oncology, but very few practicing oncologists are that well versed in it, came into it with that level of knowledge. And I'm afraid that what we're actually seeing in these reports is an arms race of we're going to deliver so many markers that we're gonna find something for everybody. But to me, this is really a mistake. That if you just lower the bar enough, yeah, you can find something, some pill to give somebody, but it's going to be often predicated on preclinical data or something very tenuous. And the problem is, if you give that to the to the hapless oncologist trying to deal with this 70, 90-page report on all of these patients, when they come back with 20 biomarkers and very little context, and it's not clear what should bubble up to the top, it's not just very easy to obscure something that really matters because it's surrounded by a whole lot of junk. But the potential that you're going to give someone everolimus for that very tenuous biomarker based on dubious data instead of the treatment that really could have helped them. But there's this concept that if you just squint hard enough at the NGS report, there's got to be some pill there for them.
Well, my feeling is there's not one, but two torrential data streams that the oncologist is having to deal with. So again, the nice problem that we have is research is continuing at breakneck speed, and who can really wrap their arms around the literature that's changing in real time? And then second, you're getting just an absolute torrent of data points on each individual patient. When you're on NGS, you find all these things, variants of unknown significance. How do you act on those appropriately and conscionably in clinic? And I guess the third party here is actually the patients themselves are getting so savvy and demanding this testing, sometimes in clinical contexts where it may not be appropriate.
Yeah. Eddie, do you have any thoughts on how we can potentially narrow the gap between the way that the subspecialists are interacting at meetings like this at the very bleeding edge of new information, and just trying to get the core concepts and the most established treatments out to the communities and the patients where they're actually getting treated very often?
Yeah, one of the questions that I would have is there are some places that are looking at putting together sort of molecular tumor boards, and even molecular tumor boards where there may be some things remotely. And the one that I always think about for myself is in ALK gene rearrangements, for instance. There was a very nice paper out of the group in Boston where they had a patient who got a sequence of different ALK inhibitors, and then by X-ray crystallography, they were able to show that you would in fact be able to use crizotinib again, and that they would now be sensitive to it. And even for me, who is specialized, that was a great example. I would love to talk to them and see sort of where's the reality in that, in terms of I don't have a great relationship with my X-ray crystallographer. How exactly can I apply that in the real world setting? But I have a feeling that way I feel on that specific topic is probably how people in the community feel very frequently. And
I just feel like some of this gets like Marie Antoinette, like, well, you just do a 9th repeat biopsy and then you cobble together a regimen based on the 4 investigational agents we had, and you find the 1 in 100 case report and then you publish it.
Well, I know these two guys, Watson and Crick. I'll get you their names. I think the era of paternalism needs to end, but I also think that the notion that oncology is 2 tribes, sort of the ivory tower academic elite, and then I've heard this phrase more than once at this meeting used almost as an epithet, the community oncologists, often said with some disdain. We're on the same team. There really should not be an us versus them. And Jack, I was thinking about this. I think we're living in an era, it's almost like the Gutenberg press has come back around. So, yes, traditional peer-reviewed publications matter, but let's be honest. A very busy practicing oncologist out in the community or an academic setting, it's getting increasingly difficult to sit down and really dissect every journal paper with the rigor that you might want to. And so what I think we have the opportunity to do is, again, get rid of this notion that one group is better than the other, realize that we can only work in synergy, and frankly, you and I, we're very interested in the effects of social media on not just patients but practice. And I think there is a way there to disseminate important information almost in bite-sized pieces. Twitter is obviously one way of doing that. I actually think YouTube is another way of doing that. And you and I both know that the pathologist Gerard Gardner has sort of revolutionized teaching other pathologists about very specialized cases. And I think his exact quote was, my YouTube videos teach while I'm asleep.
Right.
And so I think we're sometimes a little tenuous or tentative, I should say, about using these new means of communication, but they're there and they're incredibly powerful if we just harness them correctly.
Well, I think that my concern is that the bottleneck is less what to do for that third acquired resistance development, but more on just getting people access to the things that have proven value much earlier on. That is low yield. That's very high yield, and it's the concept of the cancer ground shot as opposed to the cancer moonshot. This was Bishal Giawali kind of introduced this in a Lancet editorial, and I think it elegantly explains the concept that we just need to make sure that we're covering the basics before worrying about getting everyone to the moon first.
Crawl before you can walk.
Yeah, exactly. And we need to deliver the treatments that are unquestionably of proven value, making sure that people are getting the molecular testing that's clearly valuable, and if they have an ALK rearrangement, EGFR mutation, et cetera, that they get those treatments delivered to them. That is certainly going to be a high priority, and I think that it's about education. It's about partnering with the docs in the community, and not as a pejorative term.
Right.
But we need to be part of a team now. I mean, I don't do my taxes, I don't do my plumbing or electrical work. I hire or work in partnership with people when I need that, and I just think I think it would be perfectly great if we had more partnerships just as part of a team when someone in the community needs a thoracic oncologist on demand. They can see you or do a remote consult. At City of Hope, we're increasingly doing remote consults around the country and video potentially. So, these are something where it's not a risk of the patient getting seen, at a distant place, never coming back. I mean, people can get treated close to home with the confidence that they're getting what they would get at a subspecialty center, but that can even be a longitudinal relationship of as things change. There can be a dialogue about what to do. I think it's become complex enough that it would be really helpful to have a subspecialist in various things available, Intermountains and network. There's a lot of networks, and it would be attractive to be able to work together and not have this us and them concept that we're working in opposing forces.
So I'll say two things. First of all, I think the quote-unquote academic oncologists have to be, in some manner, incentivized to share their knowledge to help us deal with the fact that diagnostics are outpacing therapeutics. And again, I feel like they're often living in a publish or perish environment. They're applying for grants. They're judged on their paper output. But again, I'm increasingly wondering, there'll always be a need for very rigorous, robust manuscripts, but at least in terms of getting the message out, I would personally like to see more academics getting recognized for their efforts on social media and sort of virtual education. And the second thing I'll say is, I work at a system, you're absolutely right, Intermountain. I am supposed to be the lead GI oncologist, and what's been really wonderful about that is I've seen it affect both my colleagues, who I'm not condescending to. They are wonderful docs practicing across a very large geographic area, but also with patients. And we have used that virtual technology. Sometimes even what I do, and it sounds almost silly, is I video into an appointment just to kind of observe and reassure a patient hundreds of miles away that yes, what they are getting, to your point, Jack, is the current standard of care. And sometimes that's very reassuring.
Absolutely.
And one setup that we have that sometimes works is, for instance, on many of our trials, people at our satellite sites and even community practices that affiliate with us for research, they can accrue on studies of mine, and that does incentivize me, as you can imagine. They also enroll patients and soon will be able to bank specimens on my R01. And so there's a responsibility that goes both ways there, that they are helping me in the things that are of value at academia, but they have a practice with a whole bunch of different histologies, and I need to be available to them if there's a specific question on a complex case in my area.
Yes, and another thing just to highlight, as you said, Mark, in addition to trying to get as much good information, education to the docs, and there are a lot of physicians working on education on social media, et cetera. The patients are a great and increasingly powerful, important resource. We've seen many examples at ASCO 2019 of the power of online patient groups, particularly the narrower, molecularly defined subgroups who are geographically dispersed, but they aggregate online and they're highly motivated to get trials done so that they can move the field forward. And they partner with a lot of the leading physicians to try to make this happen. I mean, they've been a real force for providing a level of information that is just unattainable any other way. And ideally, we should partner with them. Eddie, I know you've worked with me on the GRACE, Global Resource for Advancing Cancer Education, a nonprofit for patients. And it's just a kind of belt and suspenders approach to get that information out to the docs and the patients out in the world.
We underestimate the sophistication of our patients at our peril. I've often said that the self-advocating patient is becoming the most important force, or the strongest force in healthcare. Actually, like you gentlemen, I help run a group online for people with a rare tumor syndrome, multiple endocrine neoplasia. Incidence of about 1 in 30,000, you're absolutely right. They are geographically dispersed across the US, across the world, but they gather online and they have very sophisticated discussions about treatment, and they are well aware of new findings. And again, there, our job, I think, is to help interpret research coming out of conferences like this. We had a major cautionary tale just yesterday at ASCO 2019 plenary about acting on a phase 2 trial before the phase 3 data was mature, with the expenditure of more than $1 billion on a drug in the meantime. So we have to be careful. Again, the classic, I know now cliche, balancing act between hope and hype. We really have a responsibility here. And again, I think what we're really getting at here, there's a conversation, and the conversation's happening whether we're engaged or not. So I think it's important that we raise our voices. And again, I think we really need to have sort of a united front. I've practiced in both community oncology and quote-unquote academic oncology. I see both sides, and I just hate the thought that they might be warring factions.
Yeah, no, I think that's absolutely right. We need to change the dynamic as well with the patients out there in oncology in particular, because it's high stakes. And it's chronic, and that makes it extremely amenable to getting good information online as long as it's made available to docs and to patients. But for these narrower subsets, and we're increasingly redefining how narrow is narrow, 1% or less. And it's ridiculous to think that an oncologist in the community who might see one MET exon 14 mutation positive non-small cell patient in 5 years or a career should retain that information in their mind. Of course, the patients who are looking at everything written about this are going to know about that, but that also means that you're going to need to work as a partnership with the doc, and it doesn't make your doctor an ignorant one for not knowing everything there is to know about that 0.5% subset.
Right.
Of course, and I think it's going to, the complexity presumably will go up, and it's a problem that won't get easier. But I think that starting to think about solutions now makes a lot of sense.
Absolutely. Well, Eddie, Mark, thank you so much for joining me. Great discussion, as I would have expected from you two. Also, thank you for joining us. This is Jack West for Medscape.